Assalamu alaikum wa rahmatullahi wa barakatuh. And this is very dear conference to myself and Ahmed. Been here for a long time, but this year is unique. We have a third man, Dr. Hani, come, joining us. So this is not like any other meeting where we talk together and be hard slightly on each other. It's not just showing data, easy. You can sit at home and show data. I think, lots of symposium is going on as well, which is great support from the companies. I'd like you to really utilize this where you can, all the questions you have in your mind, we are here to listen, all of us, I think, in a respect way, of course. Try to answer unanswered questions in other meetings, where sometimes, get people are so diplomatic, but we try to be in that way, of course, but try to, all the practical questions to be answered. If you look at the content, it's great. Everything from prevention to intervention. But you can see, the paradox, obesity, which we're going to discuss today, which is very interesting. Pulmonary artery hypertension, which is led by our friends here, Dr. Hani, the prevention working group he's leading now in the country. And again, the understanding that aspect is important. The areas, amyloidosis and heart failure and pulmonary hypertension, intervention. Colleagues from all the privates are here to share their cases in a, of course, a mutual way, nice way, inshallah. So, as I said, make this meeting interactive. I also ask Dr. Rahman Munir and whoever chair the sessions to make sure the timing is maintained for the question and discussion. I'll give Ahmed to give you the history behind this meeting because it's very emotional to him as well.
So, Assalamu alaikum. Welcome all for coming. Thanks all for coming today. So, thanks Dr. Abdullah, thanks Dr. Hani. So, this year actually is different, because this is 10 years since we started the Abu Dhabi Cardiology private group. So in 2015, we have the first meeting. It was me, Dr. Zahir, Dr. Andron, Dr. Ili, Dr. Rami, I think Tamer was there, Dr. Abdul Razak, Dr. Iman, Dr. Muhammad. And then later on, we have so many other colleagues. So this is actually 10 years since we have this group. And then after a couple of years, we get the idea about doing this conference. Why don't we do our conference ourselves? So Dr. Abdullah is with us from the first year. So we never, alhamdulillah, he's always with us from the first year. There was no missing for any year. Dr. Hani, he was with us from last year, the year before. Yani after he's get his freedom from last year. So the theme of this conference actually different because all of us knows each other, okay, and we have a very good relation, a very good friendship. So it's always, as Dr. Abdullah was saying, it's always interactive, and we always try to share each other opinions. Thank you all for coming, and Dr. Haniba will give his opening talk.
So just to thank both of you for allowing this forum to happen. So this is really the only cardiology meeting in Abu Dhabi. As you know, almost all the meetings are in Dubai. And thank you, Dr. Abdullah, for allowing it to be the agenda of the Emirates Cardiac Society. So one of the 4 major meetings that are part of the Emirates Cardiac Society. The unique thing I think about this meeting is it allows the cardiologists to participate equally as other meetings, a little bit different. At the same time, we're most clinical practical guidelines. So we're not doing simply randomized clinical study and here result. This is how you do it in this case, in that case, and it encompasses all of cardiology. As Dr. Abdullah mentioned, from prevention to prevention, from imaging to advanced imaging, really everything in cardiology is covered here in a way that's very practical and I think can be translated into practice. So I also want to thank Dr. Ahmed for inviting me, even when I was not in the private sector. And I think this is a long-term relationship that has a huge benefit to the community and our trainees.
Thank you very much, Dr. Hani. So I forgot to thank all our partners from the pharmaceutical companies for sharing with us and supporting this group. So I will leave now the floor for Dr. Abdullah to introduce the first session with the speakers. Thank you very much.
Thank you very much, both of you. So we'll go to the real work now. So I'll ask my Ahmed Munir, you with me, and chairing this session. So we're going to chair this session, and it's going to be on heart, weight, and risk, rethinking all truths in cardiometabolic care. Start with Dr. Amel. Obesity and cardiovascular disease.
Good afternoon, dear friends and colleagues. My pleasure to be and to be first speaker special cardiology meeting. My topic today, interesting topic. I think everyone busy investing and how cardiovascular coming, but how to prevent the okay. My topic, obesity and cardiovascular disease, risk factor, paradox, and impact of weight loss. It's me. All of us know that obesity now increasing more and more. Even it reaches pandemic proportion worldwide in adults and children. More pronounced of obesity noticed in USA. Obesity associated with numerous disease, diabetes, obstructive sleep apnea, and certain cancer. What about cardiovascular? Obesity is linked cardiovascular disease. It is a modifiable, major cardiovascular risk factor for development of many cardiovascular diseases, including starting from hypertension, atrial fibrillation, coronary heart disease, and heart failure. If obesity is associated with all these numerous cardiovascular and non-cardiovascular illness, it is expected to have a strong correlation with cardiovascular mortality and death. If we look prevalence of obesity, estimated prevalence of obesity, 988 million people estimated to live with obesity at year 2020 and expected to reach 1,556 million people by the year 20. What also can be noticed that more around 2 million cardiovascular deaths attributed to elevated body mass index. So, sure, there is unmet need for therapies that reduce cardiovascular event and support weight reduction. How to measure obesity? There is obesity indexes. BMI, body mass index, is the most commonly used. It is ratio between body weight in kg and height in meter. Overweight person is defined by BMI of 25 to 29.9. Obesity started with BMI 30 or more kg per square meter. We should know there is another indexes used, although they have more predictive power, like in, body fatness, waist circumference, and waist to hip ratio. In brief, I will go through the pathophysiology of obesity. Adipocytes act as endocrine organ. It secretes hormone, leptin hormone. Leptin hormone is responsible for control food intake and energy metabolism. When obesity happened, there is increase in leptin in addition to leptin resistance, which may be particularly related with cardiovascular disease. This slide, as you see, showing that obesity, whether it is central or peripheral, it associated with hyperleptinemia, leptin resistance, ultimately relate to insulin resistance, type 2 diabetes, hypertension, and as usual, vascular energy and myocardial infarction. Now I will go through the hemodynamic of obesity on cardiovascular structure and function. Obesity has many adverse effects on hemodynamic as it increases the filling pressure, volume, cardiac output, and workload. On structure, also it has several effects on cardiovascular structure, especially heart, as it affects the heart include left ventricular hypertrophy, dilatation, failure, atrial and ventricular remodeling. Coming to clinical consequence of obesity. All of us know that obesity, and as I mentioned previously, is associated with numerous cardiovascular and non-cardiovascular disease. Hypertension, atrial fibrillation, sleep apnea, cancer, everything mostly is related to obesity. But now I'll choose one subject. This coming from Jack, state-of-art review relation between obesity and sudden cardiac death. It is published in November 2024. In this subject, they mentioned that obesity-related sudden cardiac death an increasingly important public health problem and warranted specific investigative focus on improving the risk stratification and prevention. From epidemiological evidence, we can see that obesity and sudden cardiac death noted increase with increased BMI and particularly visceral obesity increase the risk of sudden cardiac death. One meta-analysis showed 16% increase in sudden cardiac death with every 5-unit increment in body mass index. Also, from autopsy, summarize that the most common autopsy finding among obese sudden cardiac death case, cardiac hypertrophy and coronary artery disease. Coming to potential mechanism of lethal arrhythmia, it may be due structural remodeling of the heart associated with obesity as well as fatty heart. Sudden cardiac death, risk stratification and prevention. We have defect in this point as still now currently used only assessment of left ventricular ejection fraction and implantation of ICD in high-risk patient, although we need accurate sudden cardiac death stratification in obesity require combination of various biomarkers, metabolic alteration, cardiovascular imaging, ECG, along with more sophisticated measurement of composition and fat distribution. What is future? There is future research for detection and prevention of sudden cardiac death, included mediator for sudden cardiac death in obesity, as well as identifying potential therapeutic target, emerging metric body composition. Also, we need targeted community-specific education and preventive health care have the potential to improve the early diagnosis and sudden cardiac death prevention. Obesity paradox. Maybe you heard this before or you didn't hear, but it is coming and spreading obesity paradox. So now we explain, is it still valid? Still this? What is obesity paradox? Obesity paradox suggests that individual with overweight and obesity with established cardiovascular disease may have lower mortality rate compared to lean patient with identical cardiovascular disease. The opposite of our belief and our studies, obesity increases the risk. But in this paradox, they said no. Obese has more better cardiovascular benefit, especially in patients with heart disease, than lean person. How it's come? To know this obesity paradox highlight how complicated this relation. Why? Now, recent researches, both one explain and other criticize, challenge the paradox. Let us to go to criticism as its inability to distinguish between adipose tissue, skeletal weight, and muscle. BMI measure all the human, its bone, muscle, and fat. So it should not be the good measurement for obesity. Also, it is logical to expect more accurate measurement of adipose percentage would have a stronger correlation with cardiovascular mortality and may override the obesity paradox. So if we centered on fat tissue, I think the result it will be better. They mentioned in this subject that conflict result that come from these studies used BMI with circumference and obesity, abdominal obesity, as their depending measurement. So conflict coming from this point. Second criticism for this obesity paradox coming from reverse causation. What does it mean? Patient has disease. Disease cause weight loss. So if the disease itself cause weight loss, what expected from the prognosis? Sure, it will be bad prognosis. The same also, weight loss can come in, he didn't have the chronic disease, but he has depression. So he has also weight loss and more bad prognosis. So the studies with obesity paradox, didn't even differentiate if this weight loss purposeful, يعني needed patient do it, or unintentional weight loss because of disease. When connecting obesity paradox and the cardiovascular risk factor, started by physical fitness. With patient with physical fitness usually has mild overweight, so expected to has good prognosis if he is physically fit. Logic. Coming to other risk factor, cigarette smoking. When cigarette smoking by itself decrease the body weight and associated with increased mortality, especially if associated with cancer or chronic lung disease. So what expected of this patient with low body weight? He will have bad cardiovascular prognosis. Third, that in obesity, there is greater metabolic reserve because of their size, and this reserve may provide advantage during a catabolic state, heart failure or myocardial infarction. It could be. After we finished from criticism about this obesity paradox, I will go through status of weight reduction. What we expect? Weight reduction will reduce the cardiovascular, or it will make it bad, as obesity paradox mentioned. Let me to start how to do weight reduction. First way for weight reduction is exercise training, lifestyle intervention, exercise, weight reduction with caloric restriction. Which important this, and one of the studies showed that nearly 60% reduction in risk of developing diabetes considered better than if started metformin for the same patient. Coming to our point, cardiovascular. Studied non-pharmacological therapy in cardiovascular disease for weight reduction has been cardiac rehabilitation and exercise training result in 37 reduction in prevalence of cardiovascular disease. So we have benefit if purposeful. Second, pharmacological therapy of obesity. There is hundreds of obesity drugs that reduce the weight. Almost, we know almost of them. But in my talk, I used or I start with
Laura, can we
novel.
conclude, please? Timing is.
Okay, only one slide. Novel obesity therapy such as GLP-1 receptor agonist, semaglutide, tirzepatide, with their proven efficacy in reducing weight and cardiovascular morbidity and mortality. One of the emerging studies, select trial, which is randomized placebo-controlled trial involving more than 17,000 patients with pre-existing cardiovascular disease, overweight, obesity, but without diabetes. The result of this study showed that there is superiority that weekly subcutaneous semaglutide of those 2.4 was superior to placebo in reducing incidence of composite cardiovascular death, non-fatal MI, and non-fatal stroke. This is the result of the study. Last measurement, bariatric surgery. Currently, more studies are showing that surgical procedure are associated with short and long-term improvement in the major morbidity, all cause mortality in obese patients. Hypertensive patients, they have the benefit short term, 2 to 3 years, but after 6 to 8 years, this effect is reduced. Coming to final, the summary. Sorry, go ahead. Obesity is well-established independent risk factor for development of many cardiovascular disease and numerous comorbidity. Obesity-related sudden cardiac death is an increasingly important public health problem, warranting specific investigative focus on improving risk stratification and prevention. Constellation of data still support purposeful weight reduction in prevention and treatment of cardiovascular disease. Obesity paradox refers to large volume of data showing improved short and moderate term prognosis of class 1 obese overweight patient compared to non-obese patient who have cardiovascular disease. Counterintuitive nature of this paradox has resulted in many criticism, limitation of BMI. So further research is needed in all this area. And if the current obesity epidemic continue by this way, we may soon be witness on unfortunate end to steady life expectancy. Thank you.
Thank you very much, Doctora. So that was very nice. It's very difficult to keep it in 15 minutes, but try, the speakers, please try to finish on time so we have time for at least a question or two, so we can keep your attention. This paradox, I think nicely, as she said, being rejected by 2 randomized clinical trial, which showed nicely. I think we'll be discuss that more. Dr. Ahmed, you want to introduce next?
Thank you very much, Dr. Ahmed. Thank you very much. So I will introduce now Dr. Ayman Ahmed. He's a consultant cardiologist in the Ultra Medical Center, and he's going to give us some insights about the obesity, particularly related to the GLP-1 receptor agonist. Please, Dr. Ayman.
Good afternoon. Good afternoon, everyone. Afternoon, everyone. Sorry for the voice. Some the relation between and cardiovascular disease. All of our new patient, the guideline and the mechanism of action. Dr. Ahmed just illustrated some link between obesity and cardiovascular disease. And the reflection, the link between to reduce lipid turnover and tissue and inflammation. This will be finally cardiovascular disease and type 2 diabetes. Here's how go visceral fat, cardiovascular disease, inflammation, and finally atherosclerosis. Some unmet need therapies that reduce cardiovascular events and support the weight management. Effective interventions that lower cardiovascular event and death are greatly needed. Overweight and obesity is the risk of cardiovascular event even in absence of other metabolic disease. Here we will find that and this is the consequence of overweight and obesity. Cancer shots body 2005. Number A. How is it life between cardiovascular and also cardiovascular disease? Factor five factor primary. Blood sugar, primary, vascular, and cardiovascular. Current heavy intervention ideate or medical as a other operation. Cardiometabolic mechanism will have some also other muscular heart. All these we'll see. Some are directly, some are indirectly. Here's the study. Through an action through IP moving the action drugs and causes heart failure, atherosclerosis, myocardial problem. Actually, over one group of one is substance with are good. Here, that is here we go to clinical studies. Most of them favor cardiac event. Most of them other randomized trial. Some published by safety. Other prevention was not that have the same. Also, we have some new trials going. During all the pharmacological intervention, have 50 trials with trials 50 efficacy and still waiting for other drugs trial to be completed. Just to rise over studies which go to non-randomized clinical trial. Find coronary artery function that this trial cardiac guideline as well upscaling upscaling last medication action then in 2023 for cardiovascular management in patients with diabetes, it is better to use the medication with proof effect like GLP-1 and SGLT. Then the recommendation going up with diabetes with or without cardiovascular disease as class 2A, level of evidence B, either category of patient. Then recently, with chronic cardiovascular disease and overweight obesity, GLP-1 receptor agonists can be beneficial, going to class 1A and class level of evidence A. With the event preventing metabolic anti-inflammatory drugs in 2024, and based on new the trial, the recommendation going with we can use GLP-1 receptor agonist should be considered in overweight patient, obese with chronic coronary syndrome, with or without diabetes to reduce the cardiovascular risk. And this also was evident in 2024 recommendation on the GLP-1 receptor agonist. It has recommendation to be 1A in chronic coronary syndrome patient. And also we note that in the Egyptian European Society of Cardiology guideline, recommendation on weight loss in patients with atrial fibrillation was also advised. This is away from ischemic heart disease, but at least it has some evidence in relation between atrial fibrillation and obesity. So prevention of future cardiovascular events should be addressed in people with cardiovascular disease and obesity using evidence-based treatment. Recently, GLP-1 receptor reduced the risk of MACE by 20% in recent trials, with beneficial effect across cardiovascular outcome and including mortality and in people with cardiovascular disease and overweight and obesity. The safety profile of this medication was established through many trials. Here we'll summarize the issue. GLP-1 agonists appear to have cardioprotective effect in people with or without type 2 diabetes. Starting from preclinical highlights, the effect of native GLP-1 and the variety of GLP-1 receptor agonists for reduction of anti-inflammatory cytokine monocyte adhesion and the plate formation, followed by non-randomized and randomized trials underlying the favorable cardiovascular effect. The evidence support an anti-atherosclerotic effect of GLP-1 receptor agonists. Indirect evidence suggests that at least in the effect, this effect might be independent of improvement of glycemic level and weight. So for future direction, looking beyond GLP-1 receptor agonist, dual and triple agonist, combining GLP-1 receptor agonist with complementary agonist activities at the other society and metabolic receptors are now reaching the market. Further trials are much needed, focusing on their pleiotropic, anti-inflammatory, and cardiovascular effect in order to maximize their potential and applicability beyond weight loss and diabetes in various cardiovascular disease topics like heart failure and arrhythmia and hypertension.
يعطيك العافية. Thank you very much. That was great to keep on time, 2 minutes and 20 seconds. Excellent, Dr. Ayman. So when you come to management of obesity, focus on other, entities of this medication. So we'll discuss this more, inshallah. Now we'll move to vascular surgeon, Dr. Abdurrahman Maher from Mediclinic, to take us about a case, I think very contrast nephropathy from legend to lie, rethinking kidney risk beyond the score. Welcome, Doctor.
Assalamu alaikum. Thank you, Mr. Chairman, and thank you, Dr. Munir. It takes a lot of passion for a vascular surgeon to present on a medical topic and avoid showing all the good cases that we do. I am here to present a 12-year-old paper, but it's definitely not out of touch. A topic that I'm presenting today has no more doubt. It's here as a guidance for those of us who would like to practice evidence-based medicine. Those who do not follow evidence-based medicine, for them it's the same. Whatever you say, it's not different. Why am I here? A request from my respected colleagues, a talk of desperation, because I've given this talk privately and publicly many times, yet the response is suboptimal. To remind those who like to be reminded, to remind those who do not like to be reminded, and to inform those who do not know. What is the clinical question that I have today? It's a clinical question that we face on a daily basis. Dr. Muhammad, your patient who had coronary intervention, has got a bit of abdominal pain, a bit of hemoglobin drop, but we cannot do a CT scan to look for retroperitoneal bleeding because his creatinine is 150 or 200. Are you happy for us to give the contrast despite the high creatinine? And often the results, unfortunately, is delaying the indicated study until the patient is unstable. Then do the indicated study, but it's too little too late. So what is the research question that we have? First of all, what is the so-called contrast-induced nephropathy? It's a transient increase in the creatinine, more than 0.5 milligram per DL, within 24 to 72 hours of receiving a contrast agent. This was discovered initially by cardiologists from an era in the 60s, 70s, and 80s where we're doing coronary interventions. And then proven in the lab by injecting directly into the renal artery a neat iodinated contrast that showed some nephrotoxicity. Therefore, the suggested mechanism was two things. First, suggestion that the contrast has direct nephrotoxic effect, which was never proven. Second, that the contrast has nitric oxide mediated vasoconstrictive effect of the renal vessels, which eventually can cause acute kidney injury. However, the cause link was never established. Reason being, number one, all these studies were arterial studies in the era where we used a lot of contrast, coronary mainly, with pre-renal cause and cardiogenic shock and other confounding factors. Whenever we did a retrospective study, surprisingly, and due to selection bias, the non-contrast group have higher prevalence of acute kidney injury. Because obviously the non-contrast group usually are selected of the high risk group that don't receive contrast. So this is a disclaimer now. I'm here to talk about intravenous contrast during CT. I am not talking about contrast that you give during your coronary intervention. It is slightly more complicated then. We are talking about IV contrast. The research question was to compare the incidence of acute kidney injury between a contrast and non-contrast group after adjusting all these potential confounding variables. Mayo Clinic is known for over-investigating and over-servicing their patients. Everyone that walks through their door will get a lot of labs, a lot of CTs, to the degree that they are used, Mr. Chairman, as a reference for labs. When you want to know what is the normal creatinine for a population, you go to Mayo Clinic database. So we have started with over 1 million CT scans. After some of exclusion criteria, we end up with 157,000 scans, divided into two groups, contrast group and non-contrast group. The outcome was AKI, acute kidney injury, particularly contrast-induced nephropathy, being a transient AKI, not a chronic kidney injury. So a brief refreshment about statistics. There's something called propensity score analysis. Whenever you cannot do randomization and you have an observation study only, you try and alleviate observation bias and selection bias by what we call propensity score analysis. You collect data, like for example, in this case, the suggested risk factor is diabetes, age, amount of contrast, previous chronic kidney disease. You collect all these data and subdivide the groups by many means to alleviate the effect of the confounding factor in what we call pseudo-randomization. It is used whenever we cannot do proper randomized control study. It has its own limitation. It only alleviate or eradicate or erase selection and observation bias, but you need 10 times the sample size to get a powerful study, which we have here. So the variables, we said we collected demographics, comorbidities, serum creatinine, and then we did stratification. The outcome was how much contrast and no contrast as an intervention and who get acute kidney injury. Then they did propensity score analysis by three means: stratification into three groups based on kidney function, low risk group, intermediate risk, high risk based on kidney function being less than 1, 1.5 or more than 2 milligram per DL. And then they did one-to-one matching, which they can do due to the very big number. So we give every sample of these 150,000 a propensity score, which is the likelihood that they will get the outcome. And then we compare apple to apple and orange to orange. There is something else called counterfactual cause-effect analysis. This is a theoretical dream of a statistician, where theoretically you can use a same person as their own control. This was possible here because contrast-induced nephropathy was suggested to be a transient problem. Therefore, we had more than 4,000 patients who at one stage were subjected to the contrast scan. At the other stage, they had a non-contrast scan with 6 months or more apart. Therefore, you can use those people as their own control. And this is a great, powerful thing to do. So I will run quickly, but I'm just showing you that we have, as usual, the non-contrast group ends up having more acute kidney injury due to the selection bias. They are the high-risk patient that you're avoiding contrast in, and therefore they are getting more acute kidney injury during admission. That doesn't mean contrast is good or bad. It does not mean this is a contrast. They used to call it contrast kidney protective effect. Once you do the propensity score analysis, you see that the two groups are almost identical. The effect in amongst subgroup was the same, no effect of all these confounding factors. I will jump through this straight. Here I'm showing that acute kidney injury is more prevalent in the non-contrast group, but it corrects immediately once you correct for the odd. Since this paper came out suggesting that this is a coincidence, there is no cause relation between contrast, IV contrast, and acute kidney injury, a lot more papers came out suggesting the same, even going more bravely to say, does it really exist? Is there such thing as contrast-induced nephropathy? Currently, the name of the most conservative person will call it contrast-associated acute kidney injury. This is a consensus statement from the American College of Radiology and National Kidney Foundation last year. You can go through it, and I strongly recommend that you go through it to give you the most up-to-date practice. But the guidelines, American, Australasian, as well as European, have said that anybody with a GFR above 30 who requires intravenous contrast study, you should not hesitate, you should not delay. It's up to you as a local guideline to give fluids if it's indicated and it's safe, but this has never been showing to change the outcome. I am not here to say that that chronic kidney disease is not a risk and not a patient that should be taken seriously. In these studies, we discovered that overall mortality of a patient admitted acutely to hospital with chronic kidney disease is 20%. So this is as much as some of the ruptured arteries and some of the acute coronary situations. Yet we take it lightly. If your patient is admitted with cellulitis or just non-specific abdominal pain, and you know they have chronic kidney disease, you should manage them very carefully. But it's rather delaying the indicated study rather than the contrast that will kill this patient. And remember, cause no harm. In my view, withholding or delaying an indicated contrast CT scan in a patient due to elevated creatinine is almost a malpractice. Patient who's got perforated viscus or a patient that is bleeding, delaying the diagnosis and the definitive management will kill them, especially if they have chronic kidney disease. Thank you very much.
Beautiful. Can we have the questions, comments from all to the three speakers? Can you go to the mic, please? Get a mic there. Can I ask the questions to the doctor yourself? So you mentioned all these, and I think all of us know this: contrast-induced nephropathy association. We know this. When we speak to our patients, what we should say to the patient, and what should, as a doctor, to do? I mean, should we refer all these patients to the nephrologist? Is that something protocol? I have to use it? I mean, I do CT all the time. CT coronary angio is my everyday practice, and a little bit of slightly above the normal, they have to refer it to a nephrologist. For what reason? I mean, what they will do?
So they do not have to refer to a nephrologist. If you buy what I'm saying today and go and review it, you should, in your local center, update the guidelines. IV fluids and acetylcysteine have proven to do nothing. If the study is indicated, you should go ahead with it. The nephrologist might sometimes recommend IV fluid, and the guidelines suggest neither for or against that. But no one would stop a study or delay it. Number two, we need to propagate the message amongst the doctors and, as you said, Mr. Chairman, the patients. It is now becoming a problem with a lot of patients. The moment they hear the word contrast, they ignorantly, unfortunately, panic. We know that we take risk all the time. There is a risk when we put a cannula. Doesn't mean we stop putting a cannula. Having said that, I tend to tell my patient a white lie that this contrast we're using is not the same old contrast, which is true. We are using VisiPack. We are not using the old contrast and gastrografins and all these things that were used in the initial studies. And this has less kidney toxic effect, nephrotoxic effect. So I can reassure, and we all can reassure our patients that they're in safe hands.
Can you get a mic to the doctor here, please? So
Excuse me?
these are all transient, isn't it? I mean, we should say to our patient, if happens, it will go away, and it depends on your comorbidities and the level of your function. Yeah, please go ahead, doctor.
Again, take the question again because I was talking to the doctor.
No, that was a comment to that. But I think we have a question.
I think
to the doctor.
Dr. Iman, she has a question. Yeah.
Thank you for your excellent presentation. My question is about the peri-procedural hydration. You just mentioned that it's not recommended or it wouldn't make a difference. I mean, in our practice, we know that whenever we have a patient with renal impairment, we prefer to hydrate him peri-procedural before and after the scanning with dye. You don't recommend this, or the guidelines do not recommend this?
I said that all the studies have shown no difference. However, we are doctors, so we are very conservative. So the guidelines still suggest if GFR is less than 45 to give hydration. No guidelines suggest N-acetylcysteine, but no guidelines advise against it either. So if you're worried your patient is heart failure patient that cannot take so much fluid, you can stop it and safely stop it.
So the questions to our colleague, Dr. Ayman. Yeah, Dr. Mohammed Android,
Thank
yes,
you,
please.
thank you, Dr. Abdurrahman. So I think we have this debate before. So this is, just to make it clear, this is intravenous contrast. So it is not arterial contrast. We all have, I'm sure, Dr. Abdullah, you've had experience with the contrast-induced nephropathy post-coronary angiography, and that's definitely a fact. So with the arterial, it's no doubt is established risk of contrast-induced nephropathy. We all had it. We had a patient requiring dialysis. So just to make it clear, is it only for intravenous?
This talk purpose was for intravenous CT contrast. That was a disclaimer. Having said that, arterial, especially cardiac interventions, was never established to have a direct contrast linear relation. It's very complex because you work above the renal artery, so there's microembolization. You work in a patient who have cardiac risk factor of pre-renal disease. So all the studies have not established it, but it is a fact that acute kidney injury is a risk of coronary intervention. Is it purely contrast? Is contrast playing a role? It's too complex and it's a matter of debate.
So if you go back to the first two speakers and we talk about obesity, and I think when you see the patient, thing we do practically is BMI. And of course, what we heard from the two speakers, we should not use the BMI. I mean, what do you use, guys? I mean, you two speakers, what do you use? Do you use waist and height ratio? I think it's impractical. I don't know.
Thank you, Mr. Chairman. As I mentioned, BMI is not now has its limitation. You cannot use it, as I mentioned, because it calculates body fat, muscle, and bone. So it is not perfect for diagnosis of obesity or to use it. So better to use body fatness, only fat, or other indexes that can be used like height hip ratio. This it will help more to get more better result for the studies.
So, but Dr. Ahmed, how do you measure the fat? I mean, central. I mean, how do you do it in your practice? Come on, let's be practical, guys.
I think who's obese, he knows that he's obese, so no need for measurement.
No, now by skin fold, it can be now measured.
It's obvious.
It can be measured by skin fold. It can measure.
Yeah, I think most of the studies really look at BMI. I know, but this is what can we do? We are very Dr. Ayman, your answer.
I guess we should go patient by patient. course, I can use Dr. Ahmed with my eye, but we can go because I have one patient BMI 35. He just mass, muscle mass. No, no, it's better to go initial like the Dr. Amal said. But if we have suspicion, we can go to in-body measurement like visceral fat and total body fat and total muscle mass. This will be give us insight about how to manage because by measuring this one, we can have some reflection on insulin resistance and go for further intervention if we need. I totally agree with body mass index only is not يعني solid measurement.
So as a cardiologist, all of you presented about obesity. Are we cardiologists really, treating obesity? I mean, is that something we can say in our credentials? We are obesity. Are you comfortable treating obesity, all of you? I mean, I don't know how many cardiologists here. Are you comfortable to treat obesity? And you can say this?
I can say we are trying to manage, not treating. We will try to manage it. We can take advice of our colleague in dietitian and endocrinologist, of course, side, but we can also
So we're going to manage obesity. We have to use the proper
So
measurement.
you mean, Dr. Abdullah, treatment of obesity by drugs or?
No, I'm saying management, as Dr. Nicely said, measurement start from measurement. So if you don't do the measurement properly, you don't do that. You don't do the treatment properly. So if it's not just a medication, isn't
Yes.
it? You just need to do that thing properly.
Yes.
We are not doing it properly.
Yes, right, doctor. Only we should know how to measure obesity and then to manage. If you, by our limitation, BMI, it is not correct one. As I mentioned, patient with physical fitness, he has more muscle. So you'll find he is overweight, for example, or stage 1 obesity. He is good. So we cannot put in obesity sector. Now they are going through measuring of body fat. It is it will be the specified measurement for obesity to get right and correct result.
So that's why cardiologists should not work in silo, work with other colleagues. There are experts in obesity, cardiometabolics. That's why we do this kind of forum to work. Doctora, go ahead, please.
I just wanted to stress on this point that we all work as one team, as mentioned by the doctor, endocrinologist, dietitian, and we should know when to refer the patient for bariatric surgery. I mean, it's not an easy job to deal with obesity, but we tend to see them at the beginning because they come with other comorbidities, whether hypertension or hyperlipidemia.
Thank you very much for the very nice presentations.